rounds this morning. My presentation is a little bit fun because I get to share some data from a research study that we completed here at VCU and then take some of that data to inform a discussion about reproductive sexual health at the intersection with substance use disorders. If you don't know me, my name is Caitlin Martin. I am a generalist here at VCU as well as an addiction specialist. And so I'm working on my addiction medicine board certification right now. Here I'm the director of OBGYN addiction services, which essentially means that we work as a big team to integrate reproductive sexual health or OBGYN care with addiction treatment. The biggest thing that's under that umbrella is the OB Motivate program, where we do offer integrated OBGYN and substance use disorder treatment for pregnant and parenting women across the life course. If you have questions about how to refer patients to our program, I'm happy to answer those at the end. Okay, so we'll go ahead and get started. So these are our objectives today. As most presentations, I am going to start with some epidemiology, but I promise it's going to be very current and up to date and new slides since the last time I spoke to everyone, talking about substance use disorders and how they also are affecting men and women differently. And then we're going to dive into some of the data from what I call the Motivate survey study, which was the reproductive sexual health survey study that we did here, and then talk about some of the findings and then use that as a platform for discussion for clinical implications. Okay, so again, so objective one is to give everyone a little bit of an update about epidemiology for substance use disorders. And the big take home point is that it's not just an opioid crisis, and that women are being disproportionately impacted by the current, what we call now the overdose epidemic. The terminology has changed a little bit, especially given the increasing literature and attention that has been given to the racial disparities in substance use disorders. And so this was a paper that came out actually a couple years ago now, so that looked at our life expectancy here in the United States. And the findings were really sad. They found that after having many years of our life expectancy in the United States increasing, so people living longer, right? Probably because of advancements in medical care and some psychosocial interventions potentially. In the last few years, our life expectancy on average has decreased. And you think, gosh, that's so terrible. Why has that happened? Well, a huge driver of that has been the overdose epidemic. And so we do know, obviously, from the last decade of news stories, et cetera, that there has been this very rapid increase in deaths related to substance use, largely among young people. There are some cohorts in the older generations, especially among women with substance use related deaths, but generally it's been among young people. So therefore, if you average life expectancy across the United States, that's why it's been going down, really highlighting how this overdose epidemic is quite important, that we need to think about it on a grand public health scale. And if you look in the text of the article, they did look at differences by race, ethnicity, sex, gender, all the things that they had at least in the database. And they did find for sex differences between males and females, what they called a pronounced female disadvantage that emerged for certain major causes of death. And the causes of death that they highlighted were women were seeing, gosh, maybe they're being impacted a little bit more significantly was for substance use related deaths. So they found that even though at one point in time, an absolute number of people who die from a substance use related death, more of those people are men than women. So like today, more men will die from an overdose than women. If you look at the rate of change over time that has been occurring with regards to alcohol and drug related deaths, that rate of change has been a lot more rapid for women than men. And so we historically have thought of substance use and especially morbidity and mortality being mainly more of a man problem than a woman problem, and actually that gender gap has been narrowing in the last few years. And then in addition to that, so that's the gender differences, we also have been seeing very important racial differences too, especially in the COVID pandemic. This paper was published kind of right before they had any COVID data. But this is a pretty high impact paper that was published recently, looking at the differences between Black and white individuals and the rate of change too, kind of the same concept with regards to opioid specific related deaths. And they found that in the most recent years that the rate of change of opioid related overdose deaths has started to level off somewhat among white individuals, but unfortunately it continues to increase among Black individuals. And that's what you're seeing here from this graph that was taken from this study. And they also looked at, it was actually a pretty nifty study if you're interested in reading it. This is the title here, but they looked at the average annual percentage change in involved overdose death rates. So it's a long word, so they put it, that's what the AAPC here is referring to. Essentially, they looked to see, gosh, between 1999 and 2010, and then 2010, 2013, and 2013, 2018, they broke it up into these time intervals, and then saw what the rate of change with regards to opioid-related overdose deaths was for Black individuals compared to white individuals. And they found, and I'm bringing up the data just for Virginia, because they did break it down by state, but our numbers are reflective of the national numbers, that at the beginning of the quote overdose crisis or opioid crisis, white individuals were dying more often from overdose-related deaths due to opioids. But in the last, since 2010, that trend has flipped. And you can see here that these numbers have just become even larger. So in the most recent years, Black individuals were significantly more likely to die from an overdose related death, at least when you're looking at the rate of change during that time period. And the number is even greater than it was when white individuals were having that trend. So again, there are important racial and sex and gender disparities in the overdose crisis that are emerging now, especially in the COVID pandemic. And we're seeing from an intersectionality framework how sex, gender, and race all do intersect to lead to our highest vulnerable populations being the most affected. And I don't have to belabor COVID. So if you can imagine, COVID's been bad for a lot of things. For substance use disorders, it's been pretty bad for many reasons I won't go into. But this is a graph here from the CDC provisional deaths. So you can go online and they'll put up their most up-to-date data about overdose-related deaths, and they'll publish them for national and the state. And you can see here, this is the most recent when I got this a couple months ago, seeing this continued uptick in overdose-related deaths in the COVID-19 pandemic. We were already increasing, but it increased even more. And then when the CDC is able to, based on the data that they have, break it down by substance, we do see that you look at this, it's like literally a line going straight up, unfortunately, for opioids. And then when we see this, right, the next one underneath it is synthetic opioids, so that's fentanyl. So if you ever work on labor and delivery or antepartum, you know that you've probably had a conversation with me about how fentanyl is just everywhere now, and that we're having to rethink how, when patients do present to treatment, even how we're starting them on buprenorphine, because fentanyl is just everywhere now, and that has just changed in the last year. So, it's still opioids and it's still synthetic opioids like fentanyl that do continue to be the leading cause of deaths related to overdose. However, other substances, especially stimulants, which include cocaine, methamphetamine, for example, are also rising as important causes of deaths related to substance use. And that's this pink line down here. So again, it's still down here compared to the opioid, but you can see this trend is starting to increase. And depending on where you're looking at in the United States, this trend is more rapid than for other places. And so again, the first take-home point was that the overdose crisis is disproportionately affecting people of color, and especially women of color. And the second point of that I brought up in the epidemiology section of the talk today is that it's not just an opioid crisis, right? So we know, these are just some examples of some papers just related to pregnancy, right? Showing that it's not just overdose, it's not just an opioid crisis, that substance use usually involves more than one substance if you're treating a patient with addiction, or also there's increasing trends for lots of other substances. So even though a lot of the examples and the data I will talk about today are related specific to opioids, or we might have broken down the Motivate survey study into the opioid only population, That does not mean that it's not that we didn't look at other substances. And so it's just a lot of the examples I give are about opioids, but please remember that it's not just the opioid that's a problem right now. So now switching back a little bit more into the gender disparities, of course, we're talking about females, and I would use the word women. When we're talking about women, just because we don't have sex and gender data in this Medicaid database, so we're not able to break the two down. So we think about women can get pregnant, and therefore they can have that period of time at least once during their reproductive years where they get pregnant. So a lot of what I do, a lot of what we do, and a lot of what data comes from with regards to opioid use disorder treatment is focused on pregnancy. And so this is a snapshot of some data that we are working on right now to hopefully get published, looking at overdose related deaths among individuals with opioid use disorder here in our own state of Virginia among Medicaid members. And this is actually with pretty recent data, 2016 to 2019. And so we looked at the overdose related events here, and we broke it down by period of pregnancy as well as postpartum and preconception. So this is just among people who delivered a live birth after 20 weeks. And you can see the blue bar here is the total number of overdose events for per 100,000 members, or the rate of overdose. The red bar is the overdose rate that was among individuals who had received a medication, who had not received a medication prescription for buprenorphine or methadone within the month of their overdose. And then the tiny green bars down here, which are good, are showing that there are very few overdose events that are going to occur, that did occur among pregnant, postpartum individuals who did receive a medication for opioid use disorder in that month of the overdose event. So if you look at down here, unfortunately, I don't think I have to belabor the point that overdose events continue into pregnancy. Women, when they're pregnant, are still women, and they can still overdose. It's not like it goes away if they become pregnant, that risk. But I don't have to belabor that point with this audience like I usually do. Number two is that you see the overdose events, when we are comparing the rates during the period of the perinatal period, are lower during pregnancy. So this is the pregnancy periods right here, which is good. Pregnancy is a window of opportunity for treatment. It is a time with increased interactions with the healthcare system, et cetera. So all of the, lots, and the increased psychosocial resources, et cetera. So hopefully those things are helping to keep these rates low. But, if you know me, you know that I'm very passionate about the postpartum period and substance use disorders. You can see these overdose events just start to skyrocket postpartum, and they continue to increase. And actually the highest rates of overdose events among this population who did have a pregnancy during this time period is in the late postpartum period. So at the very end of that 12-month period, and then in the preconception period. So kind of just honing the point in that substance use disorder is, it's a chronic medical condition. I'm not going to go into the background about addiction today like I've done in prior talks, but I'm happy to talk to people about that at the end, or give that talk at another time. But it's a chronic medical condition with neurobiological basis that's shaped by one psychosocial context. And so just like diabetes and hypertension, which we all know don't go away during pregnancy because we continue to manage those during pregnancy, addiction is the same way. So we do need to make sure that we are working to identify individuals with substance use disorders throughout the life course, just like we do for other chronic medical conditions. We always say it's better to optimize your diabetes and hypertension pre-pregnancy. I would say a substance use disorder is no exception to that. So take-home points for the epidemiology section is that the intersection of substance use disorders and reproductive sexual health goes beyond pregnancy. I think we all can understand that, and the data from most recent data from our own state can also confirm that. And reproductive and sexual health, I would say, also are important components of recovery and for individuals with substance use disorder. And all patients who are seeking substance use disorder treatment within a medical model, such as at the Motivate Clinic where I work, and there's some Motivate colleagues on the call today, is that we are there to help individuals work towards recovery. What is recovery? Recovery is decreased substance use, potentially abstinence, and wellness, or an improved quality of life. And every individual, that's going to be different goals. individuals. And so for a lot of individuals, I would argue, especially for women, reproductive and sexual health are an important component of health that individuals do want to address, and they do want to make sure that they are optimizing as they're reaching their goals in recovery. But unfortunately, when we're thinking about this topic, most of the prior work that has focused on this intersection between reproductive sexual health and substance use disorder has largely focused on HIV and STI testing and treatment. And this makes sense, right? The HIV epidemic came out, a lot of money came out. And we know that injection drug use is a risk factor for HIV transmission. So it's not surprising that historically for some time now, that most of the work at this intersection has been, again, fueled by where the money is, and the money has been in this area of HIV, STI, especially for testing and treatment. So this is just one example. We have national data on this, right? This is national level data that's sponsored by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, or essentially our large federal governing body that's related to behavioral health, so substance use disorder and also mental health conditions. And so we have this data about HIV and STI in their annual survey. So again, most of the work has focused on this area. In more recent years, the second area that has received the most attention, secondary to HIV STI testing and treatment, has been contraception or family planning needs. And so that's great. And so we've had increased attention to this area too. And so we generally do know that women with substance use disorders don't use contraception as often, and their unintended pregnancy rates are extremely high. This is a secondary analysis that I did a few years ago among women who are in the MOTHER study. The MOTHER study is the pinnacle randomized controlled trial that looked at buprenorphine versus methadone for opioid use disorder in pregnancy. And among the people, we looked at intended and unintended pregnancies. And I can tell you 87%, I think it was 87% of the pregnancies among these women who were already pregnant when they enrolled in the study. So thinking about recall bias, it's still pretty high. 87% were unintended. Very few of them were intended. And we saw that potentially that with women who had an unintended pregnancy might have had lower treatment retention rates for their substance use disorder during pregnancy. So again, this area, this is just one example, has been getting more attention, and we do know the high disparities in unintended pregnancies and contraceptive use that do exist among these individuals. But as we all know here, that reproductive sexual health goes beyond these two areas. It goes beyond contraception, even though that's very important, and it goes beyond HIV testing and treatment. Again, still very important. But we do know that we do a lot more things as OBGYNs, and that providers in other areas who are treating men in reproductive sexual health also go beyond these two areas too. And these are just some examples of some areas here. And so that's what inspired the study that we completed a couple years ago at Motivate. And so we called it the Motivate study. And so we just essentially wanted to see, our primary objective was to compare the unmet reproductive sexual health needs of men and women in substance use disorder treatment. So we at the Motivate clinic, and we wanted to compare those to individuals who are receiving care for other chronic medical conditions. And we did it at the ACC clinic. Within primary care, just seeing, gosh, are the unmet reproductive sexual health needs, are they different between individuals with substance use disorder, which is a chronic medical condition, and individuals who are getting treatment for other chronic medical conditions? Because no one had ever done that before with a comparison group. We know the disparities exist, but are they different when you look at people kind of matching them by getting treatment for a chronic medical condition, as well as on sociodemographic factors? And then the secondary objective that we had was to ask patients, gosh, what are the barriers that you meet utilizing reproductive sexual health services? And we wanted to ask our participants about that too, so we can, and the long-term goal of this data is that we're going to use it, or we already are using it, to inform future studies of clinical interventions that are all kind of aimed at the big umbrella to integrate addiction medicine and reproductive sexual health. So this is a snapshot of how the study was done. It was actually a pretty simple study. So generally what we did is we did a one-time red cap survey. This was pre-COVID. And so we recruited participants from the waiting rooms of Motivate Clinic and from the waiting room of the ACC clinic within primary care. And that participants did it on an iPad when they're waiting for their providers or in between visits with their providers. And then we also performed a chart abstraction for clinical and demographic variables. And then for participants with opioid use disorder, we did abstract additional variables prospectively over a 6-month period to look at treatment outcomes, which I will mention later. And then our analyses, again, were quite simple. We're bivariate analyses comparing these two groups, the substance use disorder and the chronic medical condition group on their unmet needs. But what we did do is we did stratify all of our analyses by gender. So we did look within men and within women. And I will use the word gender, even though we did assess sex and gender separately in this study. All participants were identifying as a cisgender gender identity. And then these are just some snapshots of the things we asked on the survey. So generally our participants, we had a total of 150 women and 125 men between the two sites. They were generally in their 40s to 50s, so a little bit older than some of these other studies that have looked at reproductive sexual health, which have been among younger populations. Demographically, they looked like all of our patients at VCU who are at those clinics. So a large proportion were Black and a large proportion also had public insurance, so such as Medicaid. Not surprising. Now, when we did look at women and men separately, and we looked at comparing the addiction medicine and the primary care participants, we did generally find that but not on all of the variables, that social determinants of health had a higher burden for the participants in the addiction medicine group than in the primary care group. This is a snapshot of what our participants were getting treatment for. So again, these are representative of, again, patients at these two clinics. But addiction medicine, most of the participants were receiving treatment for opioid use disorder, and that's in congruence with what we do at the Motivate Clinic, which is at the Jackson Center on 2nd Street. And then we did have some other participants who were getting treatments for other substance use disorder, but largely opioids, and almost all these patients are receiving buprenorphine. Some of them are receiving naltrexone. And then in the primary care clinic, again, the most common things, which were not surprising, was hypertension, diabetes, chronic pain, etc. And so these are the reproductive sexual health domains that we assessed. So what we're going to do is we're just going to go through them and talk about some of them and their results, and then talk about how we can use these results to think about how we can inform our clinical care going forward to be more integrated and compassionate and non-judgmental. So I know I said at the beginning that most of the prior work has focused on contraception or family and other family planning needs, as well as HIV, STI testing and treatment. But we can't do a reproductive sexual health survey without asking those sections. So we're going to start with those because they're still extremely important. So unfortunately, we found that among the participants from Motivate Clinic, that most of them were not using any type of contraception, so 76%. And these were just among the participants who did have a current contraceptive need. So we did that by women who were less than age 51, who didn't have a hysterectomy or a tubal, etc. So we did assess that they have a current contraceptive need. Oh, we also asked them if they wanted to get pregnant. So we didn't include women who stated they wanted to get pregnant. And then you can see here, these tiny little bars over here, the 3 and 8%, these are going to be the ones, the people who are using effective methods. And then about 16% were using a highly effective method, such as a LARC. We did assess dual use, so if participants stated that they were using some type of effective contraceptive method and condoms in order to have dual use for both contraceptive needs as well as HIV, STI protection. And we actually found that no participants were using both condoms and an effective contraceptive method, actually across both groups, which is quite concerning, across the primary care and the substance use disorder groups. So again, even though I mentioned at the beginning that this is an area that has received more attention, it looks, the disparities continue. And so even though we know these things, we know these disparities, like the data I'm showing today is really not surprising. It's still just kind of honing in the point that the data that we know about the disparities in family planning needs among individuals with substance use disorder are continuing, and that data has not been translated into effective clinical interventions yet. And why is that? Well, many reasons. I'm not going to go into all of them, but some of them are just that women with substance use disorders, they face a lot of barriers to reliable contraception use if they do desire that at that time. Examples are going to be IPV, access to services. I would say probably one of the biggest ones is going to be stigma, distrust of the medical system, in addition to trauma histories too, just to name a few. And so we know that these barriers are multiple, and they're not just, someone doesn't have money. It's not saying that's a small thing, but it's not a single cause. It's pretty complex and multifactorial, showing that, gosh, even though we know all these things, you look at all these references down here, unfortunately, they have not translated into effective clinical care yet. So solutions are many, and we can talk all day about those. But I would say any type of intervention or any type of change in clinical practice, every single one is going to have to start with revamping how we provide reproductive sexual health care, including family planning care, to these individuals with compassion, and destigmatizing substance use disorders in these family planning conversations. And so we know, and data actually backs this up, that women who are receiving substance use disorder treatment, for example, they're receiving treatment, which is great. That's only 1 in 10 people in the United States receive substance use disorder treatment who need it. So that minority who are receiving treatment, they don't disclose their status of their treatment or their substance use disorder to their reproductive health providers, essentially out of anticipation of discrimination and judgment. And so I know I'm going to talk about some things that we're like, oh, well, they don't seem potentially like important, or things that you might need to work on, but we all have an opportunity to continue to reevaluate ourselves and how our implicit biases, and I know we talk about that a lot with regards to race and other minority populations, and I would argue that this is important too, that women are perceiving that reproductive health providers, even if they don't say anything, they're perceiving this judgment. And so we can work to combat that, especially as OBGYNs. So just to kind of hone in the point I just said, this study right here was a mixed method study of women receiving methadone for opioid use disorder in LA County in California. I really like this study, and they did 22 interviews and had 50 surveys. And I'm just going to highlight some of the findings from this study. I would recommend reading it. It's very eye-opening. Even for someone like me that does this every day, it was still very eye-opening of a study. I was most blown away in the study of how only 39% of the participants, so of these women receiving methadone treatment, stated yes to the statement, has anyone ever talked to you about having a safe and healthy pregnancy while on methadone? Only 39%. We all know that receiving substance use disorder treatment can lead to birth outcomes that are essentially comparable to individuals without the disease of addiction. And so receiving methadone is a safe and healthy way to have a pregnancy, especially considering the other option, which would be untreated addiction, which we do know leads to poor pregnancy outcomes. And so even myself, I find that I don't talk to patients as much about the positive things, right? About how they can have a safe and healthy pregnancy while they're receiving treatment for substance use disorder. So let's talk about that. And let's talk about your family planning needs and your pregnancy desires at this time. And only 42% stated yes to, has anyone ever talked to you about preventing pregnancy while on methadone? So again, that flip side of, again, even though I've showed you all these numbers, right, and the data that there's these disparities in high unintended pregnancy rates and low contraception use among individuals with substance use disorder, patients are not seeing that. And so there's some type of gap happening with when these patients interact with the healthcare system, with translating that data into them being provided the contraceptive methods that they do desire. And then this perceived this perception that receiving substance use disorder treatment is a bad thing goes down to the patient. So only 22% stated that they would be likely to have a healthy pregnancy while on methadone. If you know it, if you've taken care of any of my patients, you know that, ones that stay on their treatment and do well on their treatment, they do have healthy pregnancies. We have a whole Motivate clinic, Wednesday afternoons is when Dr. Tyson and I are there, and it's full of babies, right? It's full of women bringing their children in, and they're doing super great, continuing in their treatment, especially during the postpartum period. So we know this is true, but patients just don't think that. And we need to make sure that we help patients recognize those positive things. And then sadly, up to a third of them stated that they would be a, quote, bad mother if they became pregnant on methadone. So I think these are just some examples that when we are interacting with patients with substance use disorder, we generally do go to a negative attitude first, or a defeatist attitude. I mean, we're like, we do it out of goodness, right? We want to help people, but maybe changing our language to have a family planning conversation and starting with, hey, did you know that receiving treatment, you can have a healthy pregnancy? What are your pregnancy desires at this time? Let's talk about that. Starting with something on the more positive end or the more informative end too, I would argue, because patients don't recognize that either. This is this is one quote. I'll let you read it from the study, just to kind of hone in some of the examples that they gave from their qualitative interviews of how patients do perceive these microaggressions, I would say, too, and the implicit biases that providers have. And this is, again, this was not specific to OBGYN. A lot of their examples were from across the healthcare system. In different specialties, but just taking a moment to not just check on our own provider biases, but I would say too, we have the opportunities to teach others and to be role models for all of our students and residents, et cetera, here in our own department and elsewhere. And so we can all take a lead and as OBGYNs and working in reproductive health care to help to publicize the importance of compassion and non-judgmental care, especially in this very unique area. In the study, they did highlight some positive examples. So one of the participants said, they were nice at the clinic. The doctor was amazing. She came, she gave me everything, every information. She did not leave until she gave me all the details. That surprised me. So it's a sad quote in the fact that the participant said that surprised me, like the patient had never received comprehensive counseling, it seems like, before about her contraception. And she should have in the past, but nonetheless, she did speak about how it's not that hard. Just staying there in the room and being nice and compassionate and non-judgmental and providing all the information, it goes a long way. Okay, so moving on from contraception, we'll move on to HIV/STI testing and treatment that we did assess in the study. So we did look at participants who were sexually active at the time, and we asked them if they had had HIV and STI testing in the past 12 months. And we looked at it in all four, men and women in all the groups. And you can see here that generally more women with substance use disorders than women who were receiving treatment for other chronic medical conditions did state that they had received an HIV or STI test and treatment. So that's good. However, it was not like that for men. So men with substance use disorders were actually the lowest prevalence of stating that they had received HIV or STI treatment. So we do have a long way to go, especially for the men who are receiving substance use disorder treatment to providing this type of care. However, even though these bars look pretty good, if you're looking at them between substance use disorder and chronic medical condition, if you look up here, the past 12-month HIV and STI testing was far from universal among participants. So this is only about 50%. And so these patients who are receiving substance use disorder treatment definitely have decreased HIV and STI risk, definitely do, but do continue to have a higher risk than general population. And so we do have a long ways to go to improve our HIV and STI testing and treatment. And so, but like I mentioned before, HIV STIs go beyond testing and treatment, and we also need to think about prevention too. And so we did ask participants in our study about HIV risk behaviors, as well as PrEP use and PrEP knowledge. And we actually just published this. So how we did it, how did we focus HIV risk behaviors among these participants who were receiving substance disorder treatment? Well, we looked at the CDC criteria for PrEP indication. So who are the patients who would qualify for receiving PrEP? And this is literally just a table from the CDC that does go over the different criterias for PrEP. And so we did ask about sexual orientation in our survey, and most of our participants were heterosexual. And so they would be here in this column here, where people do qualify for PrEP because of these risk factors, such as transactional sex, recent bacterial STI, so that includes gonorrhea and chlamydia, for example, high risk of sexual partners, or inconsistent condom use, just to name a few. And so we asked all of these risk factors modified from other national surveys to assess how many of our individuals had persistent HIV risk behaviors despite being in the substance use disorder treatment. And we found that actually up to 3/4 of the participants at the Motivate clinic had an indication for PrEP. So they met the CDC criteria for needing PrEP. But unfortunately, we found that less than 20% had even heard of PrEP, and then only 5% had received PrEP. This is very sad findings. And we're currently looking at this at the Motivate Clinic to see, gosh, how we can improve this these clinical findings. And so I think there's a lot of things that we can do, but I think getting into the data can help us drive these interventions more. So how did 75% of the patients at Motivate meet criteria for PrEP? Well, we looked at those numbers and we found that most of them met criteria for PrEP based on inconsistent condom use. So that was most of the individuals, that's how they met the criteria for PrEP. The second most common reason by the CDC criteria that individuals at Motivate met criteria for PrEP use was engaging in transactional sex. And so why is this important? Well, heterosexual transmission remains the second leading cause of new infections in Virginia, and then also in our own region of Virginia. As this is just a snapshot of a report from VDH looking at the number of new cases in 2019. And MSN contact continues to be the #1 cause of new HIV cases, but heterosexual contact is #2. And so this is very important to remember that, again, receipt of substance use disorder treatment definitely reduces your HIV risk. So there's less injection drug use, for example. But we see injection drug use accounts for a smaller number of new HIV infections. And so individuals with substance use disorders, despite receiving treatment, do continue to have a heightened risk for HIV over the general population. And so what are the solutions? I'm not going to go into and belabor all these because I know that others are working on this area and I'm hoping to collaborate, but their solutions are probably going to be many: doing better job at screening, provider training in PrEP, condom use, and I would argue too, stigma related to PrEP, which is compounded on the substance use disorders themselves. Okay, so moving right along, one of the other areas that we did assess in the survey was intimate partner violence and also trauma, which I argue is a core component of reproductive and sexual health myself too. So again, we know, unfortunately, the finding that violence and trauma are very common among individuals with substance use disorder. But what we found in our study is that this violence and trauma, it continues despite even after engagement in treatment, kind of like their HIV risk behaviors. Again, they are less when people are in treatment, but they do continue into treatment. So again, another thing that we need to make sure that we are aware of. And so we looked at past 12 months. So we referenced that as recent, and we turned to interpersonal trauma because we did ask about a lot of things in addition to intimate partner violence. It wasn't just violence from intimate partner. And we found that more than 1/3 of people who were receiving treatment, and this is just among the buprenorphine patients, reported recent trauma or violence. And this included 35% of men okay, and 40% of women. And so it was quite common among both men and women reporting recent violence and trauma. So again, trauma histories and violence histories are almost universal, unfortunately, in individuals with substance use disorder when we're talking about past trauma and violence, including childhood adverse life experiences. But what we do know is that this trauma and violence does continue, including intimate partner violence. And so what we did is that we also looked at opioid use disorder treatment outcomes. So we wanted to see, does experience of this recent interpersonal trauma and violence, does it impact how they do in treatment? And actually we found that when we looked at both men and women who had recent opioid use, recent trauma or violence, we found that prospectively over the 6 months that after the trauma, or after the survey, I mean, that women, but not men, did have higher rates of substance use recurrence. So use of drugs or alcohol while receiving their buprenorphine treatment over the prospective 6 months. So showing that, again, the violence and trauma continue to be quite prevalent in this patient population, and is among both men and women, so it's extremely important among both genders. But again, when we're thinking about opioid use disorder treatment outcomes, this violence and trauma may be impacting negatively women more than men. So again, an important area that we need to think about integrating into our substance use disorder treatment, which we do at the OB Motivate program. We have a very close collaboration with Project Empower. They come to our meetings every week. We talk to them a lot. And so we do strive to do that in the OB Motivate program through our big multidisciplinary team. So that's one example of how we have incorporated this data into our clinical practices with more systematic screening and more linkage to referral to Project Empower. So like I mentioned, these findings, even though they're quite sad and they do add to literature showing that the violence and trauma continues into treatment, they're not real, and then they're not super surprising though, given again what we know about prior trauma, and especially the differences that we know exist between men and women, like I showed earlier about the differences, how they impacted their opioid use disorder treatment. And so most people probably know about the adverse childhood experiences, or the ACEs score. You can go online and check your ACEs score. It's a quantitative measure of early childhood adverse life experiences, such as abuse, household challenges, and neglect. And we know from the very original ACEs studies that ACEs are experienced more commonly, and more ACEs are experienced by girls than boys. And then we also know from the initial ACEs studies that ACEs are also associated with an increased risk of addiction later on in life. And even though it's a cross-sectional study, there is a dose-response relationship that has come up in this data, showing that the more ACEs you have, the more your risk factors increase for developing the disease of addiction. So we look at how childhood adverse life experiences kind of merge between men and women, and also this addiction thing. We're seeing that still in adults too, how this intersection between these two risks for more severe addiction, more severe risk, as well as for more women than men, is kind of converging now. And we're seeing that be persistent among adults with their recent interpersonal trauma, and seeing how it's adversely impacting treatment outcomes more for women than men. So how can we respond? So I'm going to spend a couple minutes because this data is was enlightening to see such a high prevalence of violence and trauma in our participants. So there's two things that we all can do as providers. One is we can think about better screening. And when I say better, it means it's universal, it's non-judgmental, it's compassionate screening, especially for intimate partner violence and warm linkage to services. As well as number two, adoption of universal trauma-informed practices by all providers. And that's recognizing that trauma is really common, right? It is very, very common, not just among the patients with substance use disorder, across many patient populations. And so you never know, right, when a patient has a trauma history. And so universal trauma precautions are always the right way to go. So number one, again, screening and warm linkage to services. So that here at VCU, the IVPP, Project Power, which is part of IVPP, they use the HIT screen. And so it is 4 questions. It says, how often does your partner physically hurt you, insult or talk down to you, threaten you with harm, or scream or curse at you? And it's scored on a 1 to 5 scale from never to frequently. And so that is a very well adopted, easy, clinically feasible screening tool that we actually even have in Certum Maternity in the prenatal panel. And so scores that are greater than 10 are considered high risk. But of course, we know that if they have any scores on any of these, they need to be at least addressed in some way, shape, or form. And then after this universal screening, we do need to make sure we're linking patients to services. And so we're really lucky here at VCU that we have a hospital-based violence prevention intervention program. Not all hospitals have what we have. And so Project Power is available 7 days a week, and here's their phone number. And all their information is on their website. So highly recommend collaborating with them. And so what is number 2? So number 2 is trauma-informed care. So again, I'm going to talk about some things that are going to seem really simple and maybe a little rudimentary and not, but I think we all have opportunities to improve our trauma-informed care and how we provide care to our patients, and also just to know the language and teach that to our trainees. Medical schools do a terrible job teaching medical students about trauma-informed care. They'll show up in my clinic a lot of time and not even know the term. And so just giving a term or a name to something sometimes also just helps us with teaching and effectively getting those messages across. So I'm going to talk a little bit about some pearls about trauma-informed care, and I'm happy to take some more ideas at the end too. And so when you're talking about trauma-informed care and how to integrate that in the flow of your visit, number 1 is just how your visits are done, right? So first is just giving the patient power and control whenever possible with those universal precautions. So common things to do are talk to patients, especially patients that you don't know very well, with their clothes on. So talk to them first with their clothes on, and then if they need to undress for an exam, you leave the room and then come back. Knock on the door and always wait for a response, and ask for permission to come in. And that if you're running into trouble, so if you're trying to get an exam done, you're trying to get a procedure done, and it just doesn't seem like it's going well, right? Or it just doesn't seem like there's an issue. We've all been there, right? Where you're like, I just having a gut feeling that this patient is just not doing well with the situation. Just be willing to stop and reschedule. I know we're all so busy, and I remember, especially as a resident, just being like, I really have to do this right now, but that's not always the best thing for the patient. And then the second thing is just collaborating with the patient and recognizing with your words that she's an expert on her body. So saying things like, you know your body better than anyone else. What do you think is happening? Or what do you think would be the best treatment option? And so related to that is trauma-informed communication. And so asking for permission. So asking patients, is it okay if we go ahead and do the pelvic exam now? Or let me know when you're ready to undress for the exam. Asking for permission, validating concerns. Those are all important things that I think sometimes when I'm really busy and rushed, I lapse on too, and I recognize that in myself. In OBGYN, we have especially the opportunity to trigger patients who have had past trauma. And we can do it not just with our exams and all the things I talked about, but also just in the words we use. And so these are some examples on this slide of words that we do commonly use in our specialty that can be triggering. And so not using the word bed, right? Using the word exam table. Not using the word relax. I actually think that one is quite important. So I say, take a deep breath and let your bottom, come down into the table, something along those lines. Not using the word stirrups, using the word footrest, not using the word feel. I'm going to feel your uterus now. I'm going to feel your ovaries. I'm going to use the word examine. Not saying things look good, like, oh, after you do a bimanual, everything looks good. Like, no, everything is very healthy and normal. So some of those words, again, they're so sometimes ingrained in us from our training and from years of experience. But these types of words can be triggering to patients who have had a history of trauma and violence. And so taking those steps can be challenging. I'll find myself, lapsing a lot in these. when I get tired or busy, but it is important and it can really make a difference for a patient. And then I don't really have to go into our exams. You can recognize that our exams 100% can be triggering to patients who have had a history of trauma or violence. And so that is a common one that we do know about. And so there are simple things that a lot of us are already aware of that we can do, right? Decreasing all the noise in the room, not having people come in and out of the room during an exam, low stimuli, etc., taking your time. And that when patients start to act, I would say, different in a situation, like maybe you're in a situation, it's maybe not a pelvic exam, maybe you're just talking to them, or maybe you're just walking to the room, and a patient starts acting differently, right? And you are, well, like, what is happening? What is going on? We need to remember that sometimes those can be reactions to triggers. So you never know, right? I went over just the word you use can be a triggering for a patient who has a history of violence and trauma. And so, the pinnacle of trauma-informed care is asking someone in front of you, what happened to you, right? Rather than asking, what's wrong with you? And so a lot of times we might have patients in our office who are just like, we just want to say, what is wrong with you? Like, what is happening? But a trauma-informed approach would be taking a moment and asking, gosh, in your head at least, what happened to you? And then asking the patient, what did happen to you? At least in the moment, that to identify what the trigger was and responding that with compassion and patience. Okay, so we're at the end. I'm just going, and I'm not going to have time, unfortunately, to go through all the other areas that we assessed in our survey, but I'll just point out some of the main findings because some of them are interesting, I would say, to some of the other people in different specialties. So we did ask about cancer prevention from a preventative care standpoint. We found that actually most women at the substance use disorder, and getting substance use disorder treatment, actually had received a pap smear in time, or at least they stated that they had. And we had used specific wording to make sure that they knew it was a pap test rather than just a pelvic exam, which is good. Sadly, though, we found that only 46% of women who needed to have a mammogram had received it within the timely fashion per guidelines, and only 32% of women who were less than 45 years old had received the HPV vaccine, and actually no men had received the HPV vaccine. So again, big opportunities for us to work on better integration. We asked about menstrual poverty. So we asked participants if in the past, I think it was year, did they ever need menstrual hygiene products but didn't have enough money to buy them? Unfortunately, we found that 81% of patients did say that they did have that menstrual poverty. And actually most patients stated that they would like to receive those products that they were available at the clinic. And after we published these findings last year, we actually met with the nursing staff and all the staff at Motivate, and they started to have some of these products there available to patients when they need it. We asked about chronic pelvic pain and sexual dysfunction, and we found that it's quite prevalent in our patient population, similar to national standards and a little bit higher, but definitely we found a higher prevalence of chronic pelvic pain in our opioid use disorder population compared to the ACC primary care population. We also asked about sexual dysfunction, and we found it to be quite prevalent. So we found about a third of patients met sexual dysfunction criteria using validated scales, and 44% stated that they were dissatisfied with their sexual life, and across multiple components. And then we also asked patients if they had ever received any infertility treatments, and if was there ever a time when they wanted treatment for infertility or when they weren't able to get it. And we found that only 8% of patients who stated they needed infertility treatment had received that evaluation or treatment. So to end, gosh, I showed a lot of sad data, but also there's room for interventions. We started to ask the patients to guide us on how to fix this. What are the barriers? And we found that the biggest barriers that they stated they had were cost, fear of judgment or discrimination, which I already talked about, and social determinants of health, such as childcare insecurity. So in general, we need to think about, gosh, how can we, in a multidisciplinary way, eliminate these disparities? And those barriers that the patients talked about are, can guide us. We need to prioritize the integration of care. So when a patient comes in, doing as many things in one visit as possible. We need to address social determinants of health. We need to collaborate more between the different specialties. And then I went on the most, I would say, about providing compassionate, non-judgmental, trauma-informed care. So I'll end here and take any questions. On the slide is the QR code for people from OBGYN who need to address their attendance. And then this is the slide that I give at the end of all my talks, talking about person-first language for addiction. And just, it's a 2-page document, it's free. Here's the citation and here's the website to talk about, gosh, how can we improve our language as clinicians to take leadership in destigmatizing the disease of addiction. And so I encourage you to check it out or ask me for it. And I'll take any questions.
Hey, Dr. Martin, I do have a question.
Yes.
My question is, when you were talking about trauma-informed care, one thing that I found as a barrier just in our clinic there are certain patients who have a past history of certain things that have happened, rape being the most common. And prior to me even getting into the room, somehow they've learned that a male provider is coming. And so they all like shut down. And I've even had one patient was told a male provider is coming. I guess she didn't hear it. And then I walked in and she started crying and I just said hello. So I am trying to see if you have any thoughts or ideas or things to do as far as like staff preparation for, like, hey, there's a male OBGYN that does what the female OBGYNs do too, also coming, or if there's anything I can do. I found that once I get into the room, I can feel out the situation and generally get people a little bit more comfortable. But it's that first initial interaction that I sometimes find difficult. And it's not with many patients, just usually those with a history of some kind of abuse or something similar. Is that?
Yeah, that's a tough one, Lamar. I know that you encounter a little bit more than the rest of us do who are not male providers. So I'm welcome if anyone else has the logistic suggestions in the clinic. I would say one of the pinnacles of trauma-informed care is asking permission. And so it's informing patients ahead of time, giving them, being patient to let them process information at their pace and asking permission. So I would say maybe looking at the flow, especially when you go out and practice, you're going to have a lot more control over how your clinic is run. So looking at the flow of how your patients are, from that very first phone call, right, to schedule their visit all the way till they walk in. Where are the opportunities for me to make sure that I'm being patient and letting the patient take their time to process information and ask for permission? And I think maybe I'm saying the ask for permission one because there might be opportunities way up ahead of time before they're in the office in the clinic, which might be triggering enough for them. So they might have come in and seen the exam room, and that might have started the whole process. And then you're kind of in a place where you're not doing super great in the first place. So maybe starting earlier in the game and asking for permission from patients.
Okay, perfect. That's very helpful. Thank you.
Well, I would just encourage people for the trauma-informed care. I know recently I've been looking into seeing what type of trainings are available for the OB Motivate program. But on the note of Lamar's question and just kind of summing that up too, it is important to recognize that trauma-informed care is important for everyone who interacts with the patients. And so having dedicated trainings can be very helpful, and making sure that it's not just the doctors at the trainings will be very important. And so I've talked to Procter & Power before to get their advice, and also to social workers such as Carly, who are to get resources. So for all the graduating residents, when you go out and practice, I would encourage you, once you get your feet settled, to take a moment to look at your practice and how your practice is run, and think about how you can integrate trauma-informed care pearls into that across the timeline, again, from when the patient first interacts with your system all the way till when you see them. Sometimes some of these things might take more time. It might take a couple minutes. And I know out in private practice, that's really, really hard. But think about how trauma and violence are so common and how in the long run, it actually probably saves you time and also is better for the patient. On the slide here are just some quotes just to end, if you want to read them, from patients in the study that we recently had accepted for publication, highlighting the, again, the stigma and discrimination that I mentioned earlier, to hone in the point just some more. And I'm happy to take any other questions.
Hey, Dr. Martin, thanks for such a great talk. The pearls and language were really helpful and some awesome takeaways. In my practice with predominantly cancer population, I see a lot of pelvic pain as a result of cancer, but also as a result of previous trauma. Do you have any tips on distinguishing? And is it important to distinguish? And is there a way to treat chronic pelvic pain when it's influenced by prior trauma that's different than what I would normally do for like cancer pelvic pain?
The answer is yes. Thank you so much, Dr. Sullivan. So PTSD is extremely common in chronic pelvic pain populations. It's like 50% or something. Just to give an example of one diagnosis that we do have in the medical community that represents prior trauma. And so there, we do know that a trauma history does change kind of the way your brain works, right? It changes the way you process information. It changes the way you neurocognitively function. And so pain is just kind of amplifies all of that. And so we do know that having a multidisciplinary approach to pain treatment, especially for patients who have a history of trauma, including pelvic pain patients, is going to be important. So for those patients, on a logistical standpoint, it is important to make sure that they do have a mental health provider. And this, I would say, someone who's a counselor or a therapist and a trained mental health provider, who can do regular psychotherapy with them that's related, and they can talk about the pain and also talk about the trauma if needed, or at least the trauma response. And I have found that talking with their providers, if they do have one, and saying, hey, do you mind if I talk to your therapist and tell them a little bit about the pain and what we're challenging with. You know, and I know some of the endometriosis literature, not the cancer one as much, but they have shown that non-medical factors such as catastrophizing, right? So like thinking your pain is so bad, it's never going to go away, right? That is worse in trauma patients. That actually drives their pain outcomes more than medical things. And so you could give them all the surgeries, all the treatments and everything, but what actually drives their pain the most is going to be the catastrophizing, or how they process that pain neurocognitively. So I know that can be challenging for patients, especially with limited social support and resources, to be able to go to doctor's appointments and then also to therapy appointments with a trained mental health professional. But they do exist that do have that do take Medicaid too. And I would argue it's just as important. Those, at least if I had to pick two things for those patients to have treatment wise, it would be seeing us and then seeing a mental health provider.
That's great. Thank you.
Welcome. Okay, well, thank you so much, everyone. And I'll see everyone later.